Thank you, Mitch. Thanks for everything you're doing here. Honored to be here today. And I would say not all of medicine. My focus is dermatology, but I do keep track of the rest of medicine too. So I'll be sharing things that have been researched in other specialties as well. Because my focus is dermatology, I'm going to spend probably the first 10 minutes on what I know in dermatology and expand to other medical specialties. And so I want to just take a backtrack here and go back all the way to October of 1980. And even decades ago, Arnold Roman, past editor of the New England Journal of Medicine, he warned us about the advent of a medical industrial complex. And fast forward now, we're seeing this play out right before our eyes decades later. And he basically warned about this new medical industrial complex that could create problems of overuse and also exercise undue influence on national health policy. He stressed that physicians must act as discerning purchasing agents for their patients and should therefore have no conflicting financial interests, which is a big problem at play right now during consolidation. He also stressed that closer attention from the public and the profession and careful study are necessary to ensure the medical industrial complex puts the interests of the public before those of stockholders. So we already talked about the CPOM, AMA's doctrine enacted many years ago. The problem with CPOM is that its principle is fantastic, but PE-backed groups and other corporations have found excellent ways to navigate around CPOM in different states using the Management Service Organization and Professional Medical Corporation entities. So let's backtrack. This all already happened once before and it failed, and we're just watching it play out a second time. And we already do have data from what happened in the 1990s. In the 1990s, PPMCs, many backed with PE investments, had billions of dollars of capital. They promised synergy in larger groups and sophisticated information systems to increase efficiency and market power to counteract insurance companies. It grew to 30 publicly traded companies with a market capitalization of 11 billion in 1990s dollars, and it peaked in 1998. However, right soon thereafter, they imploded. Many groups filed for bankruptcy, and many failed to achieve the profitability that they touted during the periods of consolidation. In the aftermath, analysts concluded that PPMCs are impractical, at a layer of admin costs, and were similar to Ponzi and pyramid schemes. Fast forward now, in the late 2010s and late 2000s and early 2010s, we're watching this play out all over again in front of our eyes. Now, the current boom was supported, past tense, by dry powder, waiting investment because there were low interest rates. However, interest rates are now climbing up because they had cheap debt financing during the 2010 period, the 2010s. And they came back saying they're going to bring value-based care. But to this date, they have not shown any data of providing value-based care. And anything we do have in the literature so far has showed that it's actually the counterproductive or the opposite of this, and they're not providing value-based care. Focusing on dermatology now, there's been at least 40 different private equity-backed groups in dermatology. Several have gone under and gone defunct. Many dermatologists have sold their practices to PE-backed groups for millions of dollars. They are financially aligned with these dermatology private equity-backed groups and serve as PE spokespeople for the promise of future equity returns. These private equity groups pay a premium for the practice of influential leaders and social media influencers with the hope that they'll use their positions to promote the PE-backed group. And this can mislead younger dermatologists, younger physicians that are unaware of their respected mentors' allegiance. Past and current presidents and board members of the AAD, ASDS, and our Mohs College, and even Dr. Pimple Popper have sold, worked for, or have agreements with dermatology private equity-backed groups. After a significant amount of pressure, the AAD did update its administrative regulations in 2019 to require disclosures of financial interests with private equity. So where is PE medicine? Pretty much everywhere. It's kind of got its tentacles in almost every facet, every subspecialty so far. But I want to talk about what's been happening in the peer-reviewed literature over the last 3, 4, 5 years. There have been several articles in JAMA Medicine talking about potential implications of private equity investments in healthcare delivery, talking about a policy framework for the growing influence of PE in healthcare delivery as well. And the American College of Physicians have put out two position statements, both one on ethical and professional implications of physician employment and healthcare business practices, and also a second one on financial profit in medicine, a position paper from ACP as well. Now, going over the entire landscape here, this shows the number of publications focusing on private equity in medicine per year over the last years, whatever's available. You can see in the 1990s, not much, early 2000s, not much as well, but you can see the huge uptick since 2018, 19, 20, 21. Now, here's a pie chart showing where these publications are and what they're focusing on. The number one area being studied is in general medicine, and dermatology is second, close behind, and even now it's probably tied with the medicine. So over close to half of the publications out there focusing on medicine, dermatology, and the next is long-term care, hospital medicine, and the rest of the subspecialties. And so let's focus on dermatology publications. The very first paper that came out was a viewpoint by the now past AMA president, Dr. Jack Resnick, a dermatologist, outlining potential consequences for the specialty and the patients. Soon thereafter, our research group out of University of Florida, we published a paper in our JAD, our main journal, which actually was temporarily withdrawn after it was pressured by private equity-backed groups and their lawyers to the journal. And our paper outlined the dermatology industrial complex, the changing landscape of dermatology, economies of scale, rise of PE. We did find, our group found that some PE firms are acquiring outlier physicians, performing extremely high numbers of skin biopsies per patient, or not performing due diligence. We also found, a New York Times reported that Advanced Dermatology and Cosmetic Surgery, which owns Bedside Dermatology, was employing non-physicians in Michigan who were independently billing highly questionable intralesional injections on vulnerable nursing home patients, of which 75% had dementia. We also did discover a Dermatology Practice Support Alliance, which is a coalition or trade group of the largest dermatology PE-backed groups. And we also talked about the end game here. Who's the next owner? Healthcare conglomerate, an IPO, or an insurance company, which ultimately own the doctors and can control which physicians their patients see. Moving on, a group out of the Northeast, they did a big study outlining trends in PE acquisitions in derm practices. One of the problems with the data set is you depend on this information, which is volunteered from PE groups themselves, so it can be often incomplete, but it did find that PE firms have a financial stake in an increasing number of derm practices from the period of 2012 to 2018. Accompanying that article was a viewpoint article by public policy experts from Johns Hopkins entitled Private Equity in Dermatology, First Do No Harm. They called for transparency and that practices should report to professional societies basic facts about ownership, use of non-physicians, and that should be curated and released to the public. They go so far to ask for a moratorium on selling practices to PE firms, and they really stressed first, do no harm to our patients. My group then out of UF, we did publish again about the evolution of PE in dermatology. We've talked about the stages, the stage 1, then stage 2 and stage 3. What's the goal here? What's the game plan of private equity, and not just derm, but all of medicine? An interesting questionnaire that we got from private equity-backed groups that we found in questionnaires was, this is what they actually go ask practices. They say, what's your revenue? How many docs? How many are the ages? When are you going to retire? How many PAs and NPs? Number of biopsies. Do you perform those? Do you read path? Nothing about quality of care, just how much do you do and how much money do you generate? That's the primary focus, which is clearly in conflict with value-based care, what they're promoting and touting. And then now switching gears a little bit, there was a group out of Michigan. They did a large survey study on residents and trainees in dermatology, and they found that most surveyed dermatology residents are wary working for PE-owned practices and believe PE strongly worsens physician autonomy, quality of patient care, and long-term salary. They did find really similar results in ophthalmology and radiology as well, where in ophthalmology, most will report they would not consider working for PE, and in radiology, most believe that corporate entities harm radiology as a specialty and would rather prefer to join independent practices, and they worry about, even if they're independent, they worry about their practice being acquired by PE in the future. And then again, coming back to dermatology, number of studies have found that PE clinics employ both a greater number of non-physician practitioners and a higher ratio of them compared to physicians. They did also find that PE-owned clinics are more likely than the control non-PE-owned groups to offer new patient appointments with non-physicians instead of doctors, because it can generate more revenue from them. And they also did find that, a study did find that front office staff at dermatology clinics may inaccurately use and potentially misleading terminology to refer to NPPs working in their clinics and not explain to patients what their role is as a member of the healthcare team. Another study that came out very recently by a group was workforce composition in PE acquired versus non-PE acquired physician practices. And they focused on three specialties: dermatology, GI, and ophthalmology. And they found that all three specialties had a higher clinician replacement ratios, both for physicians and NPPs, in PE acquired practices compared to non-PE controls. They found that the probability of physicians both entering and exiting a practice was higher at a PE acquired practice, suggesting a degree of workforce turnover. They did have a number of postulations as to why, but I won't get into that here in this short time frame. And they also found that after these practices were acquired, there was significant yearly increase in the number of non-physicians, but not physicians after acquisition. And this may be due to very obvious facts that have been found in the literature, finding that non-physicians perform on average more skin biopsies than physicians, than dermatologists, to catch a skin cancer. And most corporations or PE-backed groups don't care, because more biopsies equals more revenue. It's a no-brainer for them. And switching gears to this about biopsies and generating downstream revenue, another group did find association of PE acquisition and physician practices with changes in healthcare spending utilization. And focusing on dermatology, this group again examined the three specialties: derm, gastro, and ophthalmology between the 2016 and 2020. They did analyze commercial insurance claims and found PE acquired practices had an 11% increase in negotiated fees and a 94% increase in the share of office visits for established patients that were billed at longer than 30 minutes. Focusing just on dermatology, they found that after acquisition, interestingly for derm, negotiated fees did not increase, which is counterintuitive to PE actually saying they can bring in more revenue for doctors after acquisition. They did find, though, that the share of established patients with higher intensity visits being billed was increased, and they found that E&M and pathology service volume and total spending increased in dermatology. And they think this could be due to managerial changes or using upcoding to optimize revenues. And also, we did find both in dermatology and in ophthalmology, I worked with fellow ophthalmologists, we did find that both before and during the pandemic, and even as we're exiting the pandemic, debt valuations in both specialties have been declining or being devalued. There's been some improvement, but they're still being discounted, meaning that these groups may continue to have a hard time servicing their debt. As interest rates continue to increase, and if the Fed keeps them up here for a while, then they're going to be spending more of their revenue servicing debt as opposed to clinical care and funding operations. And we've seen a number of examples in dermatology. U.S. Dermatology Partners defaulted on a $300+ million loan several years ago. You guys know Radiology Partners, I'm sure they're being debt stressed as well. And many have heard about the Envision Chapter 11 bankruptcy case study throughout the day today, so I won't belabor that. Also, as a side note, in our debt valuation paper, we did discover that in dermatology, these PE-backed groups took over $26 million in SBA PPP loans meant for small business. So they're having trouble servicing their debt, and they're taking more free money from the government that's meant for small business. And just very recently, about 5 days ago, my group published an article, Private Equity, the Bad and the Ugly, again, focused on the history, talk about interest rates and how it's going to keep stressing the groups, how the DOJ and FTC are scrutinizing all the medicine much more, and how physician autonomy can be decreased by DPEGs, which can increase physician burnout in private equity-backed groups. Now, switching gears to other specialties, I'll go rapid fire the next 5 minutes. But nursing homes, there's been a ton of research in nursing homes, which has actually been fodder for the government to actually take action. Atul Gupta and his group found that PE ownership increases the short-term mortality of Medicare patients by 10%, implying 20,000 lives lost due to PE ownership over a 12-year period. Other declines in patient well-being, such as lower mobility. They think observed operational changes that can help explain these effects, including declines in nursing staff and lower compliance with standards. And another article by Braun and colleagues found that PE acquisition of nursing homes was associated with higher costs and increases in emergency department visits and hospitalizations for ambulatory sensitive conditions, meaning things that could be handled outside the hospital were not handled outside the hospital. And some of this research led to the White House actually announcing reforms and basically stressing that every nursing home should provide staff adequately trained to provide high quality care. Poorly performing nursing homes should be held accountable, and the public needs better information about nursing home conditions so they can find the best available options for their family members. And now, not just nursing homes, it's in hospice now too. And several articles in literature about hospice, the increasing rate of acquisitions, and the percentage of Medicare beneficiaries who receive care from PE-owned and publicly trained hospices has grown over the last decade. Also, two of our colleagues here today, Eileen Applebaum, Rosemary, they have a recent report with their center about preying on the dying. Private equity gets rich in hospice care. And then also, even in large hospitals, we've found that hospitals acquired by private equity are associated with larger increases in net income, charges, charge to cost ratios, and a case mix index. And then also anesthesia. Two separate articles in anesthesia. One focused on PE, and they found that prices paid to anesthesia practitioners increased after hospital outpatient departments and ambulatory surgery centers contract with the PMC, and were substantially higher if the PMC were receiving private equity investment. And also another separate article found that basically found that with the surprise billing legislation, it's going to put further pressure on anesthesia private equity backed practices. Another article by Eileen and Rosemary, private equity buyouts, who loses. They focused on hospitals, outpatient care, physician staffing, and emergency room services. You can read that on your own time and go into more detail. Ophthalmology also, there's burgeoning literature in this space as well. There's several articles on what the acquisition rates are over the last decade. There's a Viewpoint article about emergence of ophthalmology, PE and ophthalmology. And also going back to the same paper where dermatology examined, same thing going back to healthcare dollars. When they focus on ophthalmology, they found that after PE acquisition, allowed amounts per claim increased, and diagnostic imaging volume and total spending, but not cataract removals or eye examinations, those increased for diagnostic imaging and total spending. And same thing, gastroenterology, they're starting to get more literature in this space as well. And going back to the same article, when they focused on gastroenterology, for the second article on the bottom, they found that allowed amounts per claim increased, and the share of established patients with higher intensity visits increased as well. They did also find increases in E&M and esophagogastric volume and total spending, but not polyp or tumor removal. Also pediatrics, there's literature now in the space as well. I'm finding that PPMC affiliation associated with large increases in prices and total spending for NICU services. And also radiology has literature as well. There's a white paper on corporatization radiology, paper on PE-backed considerations for the radiology trainee, and talking about maybe even unionization as a response to corporatization in the radiology field. Women's care is also experiencing PE acquisitions as well. Several articles in the space. They did find substantial increases in PE affiliations in women's health since 2017. They found that PE-affiliated OB-GYN offices are in urban locations with an average of 2017 median household income of 24% higher than the national average for PE-acquired practices, showing they might be gravitating more higher income areas. And also another article found a major portion of fertility practices are PE-affiliated, and these practices perform an even greater portion of assisted reproductive technology cycles each year. And other quick things, ortho has literature as well. I'll skip over this. Oncology clinics as well. They just had an article about a week ago talking about the last decade of the rapid acquisitions. And there was a fitting viewpoint with this, which kind of summarizes private equity in US healthcare. Now we're going all the way from the cradle all the way to the grave with oncology, hospice, and nursing homes. And then tying this up, another article by Singh and colleagues, they focus on geographic penetration of PE across the US. And they focus on 6 specialties: derm, GI, optho, OB-GYN, ortho, and urology. And they did find a higher concentration of PE practices in the Northeast, Florida, and Arizona, which could be something to examine further for potential further examination of potential anti-competitive issues or FTC examination as well. Also, the Antitrust Institute has a big report out, came out in 2021, talking about PE investment, focused on short-term revenue generation as an anti-competitive force and anti-maverick force in healthcare, and they should be more under the regulatory and public radar. So what are all these concerns that have come out from different articles, different specialties? It's leveraged buyouts and a finite time horizon for a specific return on an investment, the loss of autonomy, leveraging of extenders and non-physicians, difficult to mix profits with patient care, long-standing history of boom and bust cycles. There are plenty of examples from the 1990s, even recent examples of failed practices and death straddle practices in this current wave of roll-ups. Geographic consolidation can refine the value of doctors. We don't know who the next owner is going to be after the flips. Ultimately, it could be insurance companies. And this is really dividing the generations. We can talk about this more in our panel later. And even the PE groups themselves, they know the game. This is from an article by Healthcare Law Monthly. And they say in the private equity cycle, one critical strategy that PE investors deliberate is the timing of a window of opportunity so as to successfully exit investment at the best possible purchase price without being the last one standing. So it's a game of musical chairs. The music's going to stop at some point, and you don't want to be the last one standing when the music stops. And even Jim Chanos, the Warren Buffett of short selling, says there's companies that can do that besides selling your practice, right? And at the day, it's just an accounting game. So just simply, let's pay a lump sum up front, and we'll keep the doctors for 5 to 7 years. Tying back to Arnold Roman from the beginning, how can we best ensure that the medical industrial complex serves the interest of patients first, and of its stockholders second? Will have to be the responsibility of the medical profession, our societies, and an informed public. And I will leave this with a quote from Brett Coldiron, because the AMA did put together the Council of Ethical and Judicial Affairs ethical principles for physicians and PE-owned practices. And in Coldiron's own words, he says this is a pretty toothless report. And he said, PE has devastated dermatology and anesthesiology, and it's coming your way. When PE-owned practices go broke, they seize their accounts receivable, and the doctors still have a non-compete. So it's a terrible situation. We need a better recommendation to work with. I'll leave you guys with that. We'll talk more on the panel, and that's my email if you have any questions. Thank you.